Yeah, so welcome to this symposium. And before we start, I wanted to recognize the presence of DVC PFA, Dr. Mbugi. We have Dr. Enika, the Principal College of Medicine, and we have Dr. Furaha Massawe, the Dean, School of Clinical Medicine. And I'm aware we have a couple of people, maybe more than 30, who are just attending the session through the online platform. So I just want to welcome you all for this quite an important presentation this morning. And today's subject is colorectal cancer, which is a huge problem in our society, in our community. And potentially the problem is preventable. We can prevent this problem in our community. And we start with our Muhimbili community and see if we can incrementally expand to the entire country. So today we are going to see what is happening with the colorectal cancer, how is it presenting, the magnitude of the problem, what are the pathogenetic mechanisms, but most importantly, we shall share our local data. We have the very current data that we gathered. It is giving us a huge picture on what is happening. And ultimately, we shall see what are the guidelines available and which one should we adopt based on our environment so that we can prevent colorectal cancer. I just wanted to say colorectal cancer is a preventable disease, but also is a curable disease as long as we catch up timely. So this morning we have Dr. Massawe, MSc surgical gastroenterologist, who will be taking us through the facts and guidelines on the disease. And Dr. Kitua will present the data, our local data that we presented, which eventually will conclude on what is the way forward towards preventing colorectal cancer. So you are so much welcome. Please, Dr. Kitua. In the very end, we shall have discussion, questions, and comments. Thank you.
Really? Good morning, everyone. So, as introduced earlier, today's topic is on colorectal cancer and mainly targeting the Muhimbili community. And it's about preventing colorectal cancer within our community. We will go through some of the essential principles and actions that are to be considered in preventing and treating colorectal cancer. So I will take you through some of the epidemiological facts, the etiological factors of developing colorectal cancer, the pathogenesis and the clinical presentation, diagnosis and treatment, and some of the insights from the local findings. Then Dr. Massawe will take us through the screening modalities and the guidelines and the standard recommendations. So to start with, the colon is the terminal part of the alimentary canal. Basically, the main functions are absorption of nutrients and electrolytes and water. However, the rectum inherently carries a risk of several diseases. And of interest today are polyps, colorectal polyps, and colorectal cancer. It's difficult to separate colorectal polyps and colorectal cancer because of the close relationship they have in the pathophysiology of developing colorectal cancer. So colorectal cancer is a significant public health concern, the third most common cancer globally, and the second most common cause of cancer-related deaths. Locally in Tanzania, colorectal cancer is the fifth commonest cancer and the fifth commonest cause of cancer-related deaths. However, there has been a six-fold increase in colorectal cancer cases over the past few years. However, in developing countries, the prevalence of colorectal cancer has been declining, and this is attributed to population-based screening, something that is not in practice in our local settings. There's no any developed colorectal cancer screening programs. So it's not only the decrease in the colorectal cancer prevalence, but also there's a significant decrease of 40 to 60% of colorectal cancer specific related deaths. Several etiological factors have been mentioned that can be a risk of developing colorectal cancer. However, the development of colorectal cancer is usually multifactorial. Not a single risk factor can be pointed out. And the factors that of significance are the non-modifiable factors. And these include increasing age, where colorectal cancer is more common in the elderly, male gender, dark-skinned individuals, a positive family history of colorectal cancer or colorectal polyps. This is very important. If anyone has a family history of a relative with a history of colorectal cancer, that means they are at an increased risk of developing this condition. Other non-modifiable factors include inflammatory bowel disease and genetic susceptibility. The modifiable risk factors, these include diet, which is high fat diet, high calorie, red meat, processed meat, and low fiber diet. Smoking and alcohol has also been implicated, including sedentary life and obesity. We need to stress a little more on alcohol because this usually raises question about moderate intake of alcohol. So as far as colorectal cancer is concerned, there is no moderation of alcohol intake. Any amount of alcohol intake increases the risk of developing colorectal cancer. So if we ever forget these risk factors, I think it's easier to remember the image that is projected that summarizes a good number of risk factors. As you can see, we have an elderly male, dark skin, and this elderly male is consuming red meat that is high in fat, smoking, and using alcohol, which is the lifestyle of most of individuals in this country who are living a Western kind of life. So before going through the pathogenesis of colorectal cancer, it is very important to understand about the polyps because this is a very important intermediate lesion towards the development of colorectal cancer. So simply polyps, this is a tissue outgrowth that protrudes from the lining of the large bowel, the mucosa. And they can generally be classified into non-neoplastic and neoplastic polyps, where the neoplastic polyps are the one with an increased risk of malignant transformation. The general prevalence of polyps, the prevalence of polyps in the general population is 15 to 40%. That is, in every 10 people in this room, at least 2 to 4 people will have colorectal polyps. Interestingly, is that 83% of these polyps are neoplastic. Most of the polyps that individuals have are polyps that have a potential to transform to malignancy. And the prevalence of neoplastic polyps increases with age. As you can see, at the age of 50, approximately 40% of individuals will have neoplastic polyps. And by the time we retire at 65, 70% of the individuals will have neoplastic polyps. So colorectal cancer can be grouped mainly into 3 categories. which include the familial cancer. These are cancers that have a familial tendency. However, there's no any defined syndrome, and the cancers that have a defined syndrome fall under the hereditary category, which account for around 6 to 8%. Most of the colorectal cancers that develop are sporadic colorectal cancers, which account for up to 85% of all cases that we see. And there are 3 defined pathways that result into the development of colorectal cancer. And as you can see through these pathways, adenoma appears to be the common intermediate step in all these pathways, which means while developing colorectal cancer, an individual will almost always have an adenoma. An adenoma usually presents as polyps, as presented in the previous slide. Someone will develop an adenoma before progressing to developing colorectal cancer. And the most common pathway is the first one. This is the chromosomal instability pathway, also termed as the adenoma to carcinoma sequence. So the progression from an adenoma to a cancer usually takes between 10 to 15 years. And this forms the basis of most of the screening programs, where we want to either pick an early cancer or pick a pre-malignant lesions. So it's very important to remember this pathophysiology and the sequence of developing colorectal cancer when thinking about screening programs. So the clinical presentation, most of individuals with colorectal cancers are asymptomatic. And whenever they develop the symptoms are usually non-specific, which makes it a little bit difficult discriminating malignant and benign conditions. And this results into late presentation of most of our patients. Most of our patients usually present after being treated for a supposedly benign condition for a while. And when they present to us, they have already developed an advanced disease. So some of the symptoms will include abdominal pain. Most of the time, this is lower abdominal pain, unexplained anemia, especially in males, and this is more common in malignancies of the right side of the colon. These tumors tend to bleed, and patients present with iron deficiency anemia. Another common presentation is altered bowel habits. This can include constipation, diarrhea, early morning mucus diarrhea, feeling of incomplete defecation, which is tenesmus. That is one of the common presentations. Another presentation is rectal bleeding. And sometimes this bleeding is usually occult, can be seen by eyes, and it will only be picked by laboratory investigations. Weight loss is one of the alarming features. Some patients will not have any of these symptoms, but will only present with weight loss. And when you have weight loss, this should always be considered an alarming feature, and malignancy has to be sorted. A small proportion of patients, about 3 to 10%, will present with emergency features, which will include features of bowel obstruction, which include vomiting, abdominal pain, abdominal distension, and absolute constipation. Perforation, patients with perforation many times will present with abdominal pain, fevers, and these patients most of the time are severely ill. And many times when you present with obstruction or perforation, the disease might have progressed to an advanced stage. Sometimes the only presentation can be features of metastasis, and the commonest site of metastasis is usually the liver. Most of these patients are symptomatic until when they present with either yellowish coloration of the eye, which is jaundice, or sometimes a mass that can be palpated during an abdominal examination. And whenever you have a liver metastasis of unknown origin, the first place to look for cancer is usually the colon. The commonest metastatic lesions in the liver are usually from the colon. So how do we investigate these patients? The investigation of choice is a colonoscopy and biopsy. So we'll have a simple illustration of what a colonoscopy is. So basically, a colonoscopy is a procedure that examines the colon, the large bowel. And this includes the insertion of a flexible tube through the colon. And the tube is usually inserted through the anus, through the colon, to the cecum, in order to visualize any lesion. And this tube, the tip of this tube usually has several things, including a camera, a light source, an irrigation channel, an air nozzle, and a biopsy channel where tissue is usually extracted. So the images that are received from the camera are usually projected in a monitor, a screen, that will visualize the internal part of the colon, the internal lining of the colon. And when a lesion is visualized, biopsy, a tissue has to be taken for biopsy in order to confirm the diagnosis. This can use some instruments such as the snare, where the lesion is extracted and sent for histological evaluation. So this is the gold standard investigation when it comes to colon cancer. So these are just some of gross descriptions of colonoscopic image. As you can see on the left side, that's an image of possibly benign polyp. And on the right side, that's possibly a cancerous growth. So these endoscopic images can also predict the histology result just on gross evaluation. After establishing a diagnosis of colorectal cancer, the next thing is usually staging of the disease, because staging will determine what modality of treatment will be given. And staging includes the use of CT scan, which is usually a CT scan of the chest, abdomen, and pelvis, in order to look for any metastatic lesions. Another investigation might include an MRI, which is most of the time specific for rectal cancers, and also a tumor marker carcinoembryonic antigen, which is used to monitor the progress of the disease after initiating treatment. The treatment is surgical. The standard treatment of colon and rectal tumors is usually surgical. However, we can also have chemotherapy, radiotherapy, and immunotherapy, depending on the stage of the disease and the biology of the disease. So after taking you through the overview of colorectal cancer, we will take you through some of the significant findings of a study that was conducted 1 year ago at Muhimbili National Hospital, which was looking on the malignancy-associated factors of colorectal polyps. And this investigation was prompted to be done because colorectal polyps is one of the uninvestigated facet of colorectal cancer in our setting. And as we have seen that polyps are a very important intermediate step towards developing colorectal cancer. So we reviewed colonoscopies that were performed in a period of 5 years, from 2017 to 2021. We had 1,125 colonoscopies. Patients that were included in the study were 583. Significant numbers were included due to several reasons, including incomplete colonoscopies, lack of verified reports, lack of histology reports. And of the 583 participants that were included, the proportion of colorectal polyps were 21.6%. And of these polyps, 38% were malignant. And 22% of these polyps were adenomatous polyps. As we said, adenomatous polyps, these are polyps that have an increased potential of transforming into malignancy. Another interesting finding was the size of the polyp. A significant number of the patients, 72%, had polyps that were greater than 10 millimeters, which is considered as a high-risk feature. Any polyp that is more than 10 millimeters, this polyp has an increased risk of transforming into malignancy. So another interesting finding is that the disease malignant polyps did not show any age, sex, or socio-economic discrimination. That means the disease was equally distributed in those elderly patients and those young adults, was equally distributed in both sex, residency, and all socio-economic classes. Strikingly is that patients who presented for screening colonoscopy accounted for only 7%. That means most of the colonoscopies were not screening colonoscopies. These were diagnostic colonoscopies for patients who have already developed symptoms. And the commonest indications included lower GI bleeding, constipation, and abdominal pain. So a summary of this finding is that there was a significantly high proportion of polyps, and most importantly, the proportion was high in the polyps that were malignant and those that harbored a malignant potential. Also, we have seen that malignant polyps showed no social demographic bias. Malignancy affected individuals of all social demographic classes. And also, we saw that there were low screening rates, which might be attributed to lack of awareness of screening for colorectal cancer, cost effectiveness, because this will be discussed by the next presenter. The gold standard screening investigations for colorectal cancer are usually more or less expensive, and also a lack of local guidelines. So with that said, I'd like to welcome the next presenter who will take us through some of the screening modalities and guidelines and recommendations.
Good morning. My name is Dr. Massawe, as I was introduced by Dr. Ali Mwanga. I'm a surgical gastroenterologist fellow. I'm going to take you through the next part of this presentation, which is the screening part. So after knowing the burden of the disease and the potential for cure when the disease is diagnosed at early stage, or when it's diagnosed the pre-malignant lesion, then it is important to discuss the screening modalities that are available. And also, this can give us a way to discuss how we can develop our own guidelines in the screening. So there are two main objectives for screening, where one is to catch the disease at early stage, and number two is to screen for pre-malignant lesions. So there are various screening tools that are available. We're going to discuss one after another, and we'll see which one is best, looking at various issues like sensitivity of the test, specific of the test, the cost. Sometimes we normally use cost-effective terminology rather than cost. And also we are going to see the setback of each of these tests. So number one common test that is done as a screening tool is colonoscopy. You saw the video of a colonoscopy where an endoscopy take a scope, which is a flexible tube, and insert it in the colon through the anus and examine the entire colon. So this is taken as a gold standard because it has 3 important benefits. Number one, you can examine the entire colon. Number 2, you can diagnose whether there's a lesion. Number 3, you can take a biopsy if it's already a cancerous lesion, but also it can offer a treatment. If you see a polyp, you can do a polypectomy, which you can send it to for histopathology examination, and you can institute treatment, or you can advise the relative on the you can advise the relative on the follow-up of this patient and other family members. There are a few setbacks that are associated with colonoscopy. Number one, it's relatively expensive as compared to the other tests. Number 2, this is a test that need anesthesia. It's normally a patient is given a low sedation. We normally use propofol. So anesthesiologist must be in the room. But also it needs bowel preparation. The patient will be given some chemicals to clear the bowels a day before the procedure. Also, it takes a bit of time, and it needs a skilled personnel. You need a endoscopist. Many times it's a surgeon or it's a medical gastroenterologist. It's also associated with complications. Complications are rarely, but when they happen, they are really serious, like perforation, bowel perforation, and bleeding. The next one is flexible sigmoidoscopy. So you see, sigmoidoscopy works almost as colonoscopy. It's only that sigmoidoscopy examines only the rectum and the sigmoid. So some part of the world use sigmoidoscopy because if you remember the distribution of colon cancer in the colon is that up to 60% of the colon cancers will develop in the rectum and the sigmoid colon. So if you use flexible sigmoidoscopy, you are targeting more than 60% of these pre-malignant lesion or colorectal cancer. The setbacks are almost the same as a colonoscopy, so I'm not going to discuss it anymore. There is another screening modality, screening tools that we call the computed tomography colonography. This one is actually, it's called a virtual colonoscopy because this is a CT scan where a patient is given a contrast to the rectum through the anus. We normally give air and liquid contrast to dilate the bowels after a patient is has cleared the bowel. And a CT scan is done where it examines the whole colon. So the sensitivity of CT colonography currently with the available technology in the world is comparable to a colonoscopy, to the, really colonoscopy. The only setback is that it can miss flat lesions, the so-called sessile lesions. But also, another setback is that you need a bowel preparation, and then you have to perform the test. And if it picks a lesion, you have to go back to colonoscopy for biopsy, or if it's a polyp, you need to go back for colonoscopy, again for polypectomy. And again, if you do a CT colonography and you see a lesion that needs a colonoscopy again, you have to use bowel preparation again. So that's a setback about the CT colonography. However, it's one of the best screening tools, I think, after colonoscopy. It's also expensive. It's time consuming, but you don't need, you only need a radiographer and you need, after the test, you need a radiologist to interpret the investigation. We have a fecal occult blood test. Fecal occult blood test is simple, it is cheap, it's not time consuming, it does not take you a day off from work. You just leave your stool sample and then you get the result. The only setback with fecal occult blood is sensitivity. It has its sensitivity is a bit low. Actually, it's about 60%, and it goes low up to 30% when for picking a polyp. Why is it important, fecal occult blood test? Because if you go back to the presentation of colon cancer, the greatest presentation of colon cancer based on the study that was done here, it was bleeding. It's a rectal bleeding. So fecal occult blood test can be applied also, and it can pick a great number of cases early. We have a fecal immunochemical test fit. This one is it's more specific than fecal occult blood test. Fecal occult blood test has a lot of false positive tests. Therefore, fecal immunochemical testing is superior in terms of specificity. But also, the setback is a bit expensive compared to fecal occult blood testing. The price is about twice as much as fecal occult blood test. So, before we develop our own screening modalities, we have to look at what other people in the world are doing. So, for instance, we have a US Multi-Society Task Force on Colorectal Guidelines. This one has divided patients to avoid screening the whole society, which is a bit expensive. It has to put people with average risk and people with added risk or increased risk. So in the people with average risk, you remember that dark skin is more riskier than Caucasians. So screening is recommended beginning at age 50 for other races, but for African Americans, it's recommended to start at age 45. And this test will be done every after, and the screen will be done every after 5 to 10 years if you are using a colonoscopy. However, if you are using a flexible sigmoidoscopy, as I said, it's recommended to do every after 5 years. If you are doing a CT colonography every after 5 years, fecal occult blood test and fecal immunochemical test fit has to be done annually because of its low sensitivity as compared to the other ones. So let's go to the increased risk group. So the increased group here, we are targeting more of familial colorectal cancer. Here, if you have a relative with colorectal cancer or adenomatous polyp in our face, if you have a colorectal cancer or adenomatous polyp, you remember adenomatous polyps, these are polyps with high risk of turning to malignant, so high potential for malignant transformation. So if you have colorectal cancer, adenomatous polyp in a first degree relative, below the age of 60. Then, or when you have colorectal cancer or adenomatous polyps in 2 or more first-degree relatives below or at any age, then it's recommended that you do a screening colonoscopy beginning at the age of 40 years prior to the age of the youngest affected immediate family member, and every after 5 years. Because of the increased risk, you don't have to wait every after 10 years as in the general or in the average group. Here you have to do it every after 5 years. But also, if you have a colorectal cancer or adenomatous polyp in a first-degree relative at more than or equal to 60 years of age, or colorectal cancer, adenomatous polyps in two or more second-degree relatives, then you need to do a screening colonoscopy beginning at age 40 and every 10 years thereafter. Here, what does it mean? If you have a first-degree relative with colorectal cancer at age 30, then you need to do a screening colonoscopy beginning at age 20, 10 years below. And when does this screening colonoscopy end? It is recommended that screening colonoscopy proceed up to the age of 75 years or 10 years below the expectancy age of a certain country. So from these guidelines, we have our recommendation or our revisions, which we have discussed, and I think Dr. Mwanga will conclude on that. So this is another group which forms about 1% of the population, which I'm not going to really talk about this. These are the high-risk group, where here we have a familial adenomatous polyposis, PAPS, we have a Lynch syndromes. It is a very high-risk group, but it forms less than 1% of the population. So we're not going to discuss much on this one. So thanks for listening. Welcome, Dr. Mwanga.
Yes, thank you very much, Dr. Kitua and Dr. Massawe, for the highlights on colorectal cancer and their screening. I just wind up by summarizing a couple of points. Number one is on the magnitude of the problem. We have seen in the US, the prevalence of colorectal cancer is declining. And the reason is very clear because of the screening, population-based screening program that they are in place in years. And we saw our local data, the prevalence, the incidence of colorectal cancer has increased 6 times what it was 5 years back. So we have the increase of colorectal cancer, and unfortunately, we don't have any screening guidelines that is in place. We also picked from our local data that from the data that we gathered, out of 538 patients, 126 presented with the polyps. And among this, 38% were malignant polyps. Malignant polyp is not synonymous to colorectal cancer. We have definition for malignant polyps, but that is early colorectal cancer. This can tell clearly that we have a problem. We have a huge problem in our community from our own local data. The other thing that we saw from this presentation is the pathway on the pathogenesis of colorectal cancer. We have multiple pathways. 3 of them are remarkable. However, all pathways for the pathogenesis of colorectal cancer goes through adenoma. Adenoma is synonymous to polyps, but adenoma have got malignant potential. So all of them go through adenoma intermediate before it goes into malignancy. And this is the time when potentially we can prevent the progression to colorectal cancer if we pick those benign lesions as part of development progression to colorectal cancer. The other thing that we noted from this presentation is the risk factors that were highlighted, including remember, among the 3 types of colorectal cancer that we see, that is, we have a sporadic type, the commonest, accounting up to 80% of all cases, but we have a familial and the hereditary one. Now, the sporadic one is the one that is the interplay of predisposing genetic predisposition plus other factors, including lifestyle, including dietary issues, and the environmental factors. And with the dietary issues, these are things that we can control, even lifestyle changes. For instance, physical inactivity has been reported from studies that they can lead to colorectal cancer. And with the physical inactivity, in a systematic review of almost 111 papers, it was reported that for you to have enough physical activity to reduce risk of colorectal cancer development, then you need at least in a week to have a vigorous physical activity, I mean running, for at least 3.5 to 4 hours per week. That is vigorous activities in a week. And for moderate activity, and the moderate activity here is like walking, then you need about 7 to 35 hours per week to reduce the risk of colorectal cancer. This is very important. So this is something that is within our hand to do. Again, with meat, red meat. Red meat is an established risk factor for colorectal cancer. And the reason is because of the high quantity of iron in the dietary red meat. And these ions produces oxygen-free radicals. These are pro-oxidant. We need antioxidant to prevent cancer development, but dietary iron are pro-oxidants. So it causes chronic mucosal damage, but also it promotes other carcinogens towards the development of colorectal cancer. Again, red meat having ions, it leads to production of nitroso compounds, which are carcinogens themselves, and many other compounds. Now, it is from the study, it is said, any increase in 100 grams per day of meat increases the risk of colorectal cancer in up to 15%. So if you eat 100 grams of red meat per day, then the study has shown that it increases the risk in up to 15% of colorectal cancer. Obesity, again, was well stipulated as a risk factor for colorectal cancer. And the obesity really causes insulin resistance. And this one leads to hyperinsulinemia. We have a lot of increased activities of insulin-like growth factor. And this one promotes cellular proliferation. And therefore, obesity, again, is linked to colorectal cancer through that pathway. Let alone saturated fats and many others. Chronic constipation, again, is said to lead to colorectal cancer. And the reason is just the stasis, the length of exposure of our mucosa to carcinogens. So please, if you have prolonged constipation, it's better you find the way to sort it. High fiber diet, to the contrary, is protective. Vitamins, vegetables and fruits, again, are protective to colorectal cancer. These are modified risk factors that we can deal with. But of notable from this presentation, again, is the screening program that are in place from Western world in specific. So as it was reported, the risk of colorectal cancer is higher among Black Americans than among whites. And therefore, even the guidelines says the start point for screening for colorectal cancer for whites is 50 years. But for Black Africans, it should be, African Americans should be 45 years. From our observation in our local settings, now we are seeing a lot of young people with colorectal cancer, young people in their 20s, a lot of them. So there is a high chance that we are dealing with even a more aggressive disease in our locality. The only problem we have is the lack of data to support and to indicate the magnitude of the problem. So even if we are going to adopt the guidelines from Western countries, might not be very effective because we don't have the data in our setup to know what is the tumor biology that we have compared to the Western world. And that prompts us to have more research in this area. The other thing that we are missing is the molecular or genetic testing. You see, like the hereditary polyposis syndromes. These are the diseases that can be diagnosed through molecular testing. Again, this is one area as the university that we need to work on. Now, coming to the recommendation from today's presentation, one is we insist on whether it is personal effort or institutional efforts, people should be screened for colorectal cancer. And there are a couple of reasons why we are saying that. Yeah, I wanted to just sum up on why did we choose this topic and why is it important to screen for colorectal cancer. One, colorectal cancer is highly prevalent. We have a huge problem with the colorectal cancer. Number two, the disease presents with a high morbidity and mortality. The morbidity is very high. And the reason come again, the third one, look, no symptoms at early stage. From the presentation that we saw from Kitua, the commonest presentation for colorectal cancer is asymptomatic. You might have no symptoms. By the time when you feel you need to go for medical attention, the disease has progressed to a more advanced stage. So being asymptomatic at the early stage leads to more morbidity and mortality because we don't detect the disease early. So this is very important, that the disease is asymptomatic. Again, it is good that the pathogenesis of colorectal cancer is predictable. The pathogenesis is predictable. We have seen clearly the pathways of pathogenesis. To each of the pathways, we have adenoma and the polyps as the intermediate stage. That means if we can catch up with at the polyp stage or adenoma, we stand a very huge chance of preventing colorectal cancer. Again, the disease is potentially curable. Colon cancer is a curable cancer if caught at the stage when it is curable. Again, this will prompt us to go towards prevention strategies. Again, the disease is potentially preventable. We have seen the sharp decline of prevalence of disease in Western world, and therefore it is preventable. How? Number one, going back to the presentation of the disease, tackle the risk factors of the disease. That's one way. But two, screening program in place. We need to start screening. And the third, we need to catch up with the early diagnosis and the treatment. Now, what is our recommendation from this presentation? One, as I said, at individual or institutional level, we need to screen for colorectal cancer. Various screening tools were highlighted, and we need to understand where do we stand. Are we the average risk individual, or are we at increased risk individual? That's very important. At increased risk individual, we mean here people with a family history of colorectal cancer. If you have your mother, your father, or your sibling who suffered colorectal cancer, then you are at the category of high-risk individual. And your screening program will be different from the person who don't have such history in the family. Anyone without family history of colorectal cancer is under the average risk. And for we as doctors, we need to establish that from the history very clear. Are there family history of colorectal cancer? If there is any first degree relative, we need to educate the patient and the relatives to start screening at an early age. So to me, I would say, at least for average risk individual, then at least from 40, of late 45, we start doing colonoscopy. And if you perform colonoscopy, the first one, screening one, it turns to be negative, nothing was detected, then after 10 years, you can have the second colonoscopy. But if during the screening colonoscopy, there was a polyp that was found, certainly it will be taken to pathologists and being analyzed. 3 types of polyps. We have hematomatous, we have hyperplastic, and the adenomatous. If it is adenomatous polyps, the malignant potential is very high. You need more regular screening. We are not going to go into the details because it depends on many issues. The degree of dysplasia, the size of the polyp itself, determine how frequently should you undertake the screening. If it is the hematomatous, it is regarded as normal. If the malignant potential is almost 0, you stick to 10 years of screening. For high-risk individual, first-degree relatives with history of colon cancer, then the time should be reduced to 5 years. Instead of having colonoscopy at 10 years, then at least after every 5 years or less. And it should start, it should begin early. As it was said, it should be 10 years earlier than the age of diagnosis of the relative who was diagnosed with colorectal cancer. For instance, if the relative was diagnosed at 30 years, then you should start screening at least from 20 years, if it is a high-risk individual. Then the problem with the colonoscopy, number one, it is expensive, because the ideal screening tool should be inexpensive, should be preferably not invasive, it should be available, and it should have high sensitivity and specificity. Colonoscopy stands the best screening tool. Of course, it is kind of invasive and it is expensive, but I would recommend colonoscopy. Fecal occult blood test is another test that you can. The only problem with fecal occult blood test is the natural aversion to stool sampling. You tell people bring the stool, they want to bring the stool. That could be a very one annually. So our recommendation is at individual or at institutional level, please let's have a colonoscopy performed. Now it's time for discussion. A few minutes for discussion, and I should recognize the presence of Dr. John Regasha, the medical director at Mwanga National Hospital. Dr. John, you are so much welcome. Please, the platform is available for discussion. Karibuni. Yes, Professor Priya, I can see your hand. You are welcome.
No. So,
if you don't mind, please in front.
No? We do have questions online.
Okay.
So, yeah,
Got it.
Professor, so, this is
Online. We have people about.
Asante, habari za asubuhi jamani. Kwanza nashukuru, I'm very happy to hear this very relevant topic, and I think it is timely, and There are some few comments that I want to say. The first one is I'm not sure, this will be a little bit controversial because maybe it is true that the incidence and the incidence of colorectal cancer has increased in the country, but it is also very, very possible that what has increased is our ability to diagnose it. So it is really, really hard to say that the incidence has gone up. Might be true, but it might also not be true. So, but that stands with our ability to follow up data. And if we're able to establish this, this is something that we need to look at. I think it is also very good, the fact that we have screening tools that we need to use, but we also need to have evidence to justify how do we screen people. I'm not sure if we could use any of the data ambazo zinatoka Marekani, kwa sababu kwanza zinasema race, kwamba ukiwa mweusi, ukiwa Caucasian, una kipato kidogo, we cannot club us kwenye hayo magroup. Kwa hiyo sisi tuko kwenye ile risk ya Americans. So maybe it is important to collect data ambazo zitatusaidia kuweza kuangalia. And it is not expensive. Naomba niseme kabisa kwamba getting this data is not expensive. Yaani kwenye kila sehemu tunayofanya colonoscopy, ukiweka karatasi pale, mgonjwa anayekuja akaandika pale, nimekubali data zangu zitumike, ukamuuliza unakula mboga za majani kiasi gani, unavuta sigara kiasi gani, unatoka Kilombero au Kasulu, we might be able to get this data and then following them up. Tunaweza tukasema kabisa kwamba these people that were diagnosed ni vijana, wanafanya mazoezi, wana nini. So maybe we could gather this data while using a very cost effective way, kwa sababu we are giving these services anyway. So I think maybe this is a challenge ambayo tunatakiwa tuifanyie wale kwenye zile point of care ambazo tunatoa hizo huduma, tuanze kukusanya hizi data kwa sababu sio gharama. I mean, we're always doing it anyhow. Wagonjwa watakuja, tutawafanyia colonoscopy, kujaza ile karatasi sio shida, tutahitaji taarifa zao anyhow. That also brings in something else. Hao wenye polyp, they might be benign, but do we know what happens in the next 10 years? So if these people wanakuja, tunawafanyia colonoscopy, tunakuta wana hiyo polyp, then if you ask them to come back in the next 5 years or in the next 1 year, you'll be able to follow them up and you can tell kwamba wenye polyp wakiwa 15 then watatu watapata malignancy in the next 5 years. So just following them up. Sababu shida muda tulionao miaka 10 inayokuja, tukianza kukusanya sasa hivi we'll have enough data kwenda kule. Cha mwisho tu ambacho nimefurahi kusikia tu I'm quite happy kwamba this is the njia ya kupunguza risk ya colorectal carcinoma ina faida nyingi sana. Inapunguza pia umaskini anyhow. Because ukitumia hela zako kidogo ulizonazo vizuri, unaweza kuwekeza na kutunza hela zako. Kwa hiyo kula nyama ni gharama zaidi kuliko kula mboga za majani na fruits basically. So basically this is what we are saying. Na pia ina maana ukiwa sio maskini utapata matatizo ya msongo wa mawazo. So you won't have mental health issues. At the same time you won't get colorectal carcinoma, hautapata diabetes na hypertension. Na pia wamesema usitembelee Mercedes. You have to run and walk. Yeah, you see. So I mean these are very, very good ways of preventing cancer and of course living healthy and balanced life. Well, maybe we need to go back huko sasa, tuanze kutembea, tule mboga za majani na matunda. Lakini hata hivyo sijui, I'm not sure pia, I'm a little bit skeptical kusema kwamba kwetu sisi kula nyama itakuwa risk. Kwa sababu tunakula finyango mbili jamani, hatuli kilo. Asante.
Thank you, Professor Furia, for your comments. Interesting. At this point, sorry, Dr. Regasha, just to introduce Dr. Harrison Chua, is the medical director at Aga Khan Hospital. We are happy, and the oncologist, we are happy to have you here. You are so much welcome. Dr. Regasha, please, you are welcome.
Okay, yes. But this is for online.
Not really.
This is like
Really online.
oh.
Okay, colleagues and gentlemen, all the fact imezingatiwa. I'm happy to see some of my colleagues here. So Ali, thank you so much for your invitation. I had to be here also to contribute. So I fully concur with what you're saying. And so the only success is to defeat colorectal cancer is to increase our capacity on detection rate. If we are not detecting it early, then we'll be defeated. And how we can do that? I think we have to use a gold standard methodology to do that, and nothing else than colonoscopy. Colonoscopy, even in East Asia countries, the way they have maneuvered it, actually even done, being invasive, needing all the kind of sedation and so forth. Some people actually in Eastern Asia, they are doing it without sedation. They just put you put in Zumbuane, and they're talking to you like that. Then we have to maneuver and see the best ways of minimizing the stigma of doing colonoscopy. And this is where the university is coming. This is where the people who are interested in colorectal medicine, to innovate and make that procedure more friendly. The colonoscopy, the machine themselves, now they are using the carbon dioxide methodology, whereby the distension that causes the vagus nerve stimulation or pain is also minimized. And I think at MNH, we managed actually to bring 2 of those colonoscopy types. So the innovation, but the big limitation are the trainees who are doing colonoscopy. Are you able to detect one? Sometimes I've realized some of the gastroenterologists who have been trained or who have even qualified, the main thing is just that lecture of moving to the seeker. But are you able to detect any, and they realize what you are seeing and have high index of suspicion? So we need expertise on that and the proper training. So the only way we can do this is to increase the expertise on the colonoscopy and the expertise on that. The fecal occult blood, Dr. Ali also mentioned, it's not only about the stool sampling, it also needs some expertise, because the issues of diet that can bring compounders on the false positive rates on that. Are we able to instruct our patients? Sababu watu wanapewa choo, siku hiyo amekuja, anaambiwa kafanye fecal occult blood. Wakati hapo amekula beetroot, amekula marage, it has also its protocol. So we need to train our physician and the clinician to follow the best practices for how to do the fecal occult blood. The other area is the high index of suspicion. You said correctly that this thing has high prevalence now. In fact, we have detected colorectal carcinomas in as age as low as 12 years of age. So it's no longer a book thing that we are discussing that we start screening at 40. As a clinician, we must have high index of suspicion. And if there are any constitutional symptoms, please don't hesitate to put somebody in this, including your family history and so forth. So Professor Furia has just mentioned something very important. Do we have data also? Hii inayozungumza kwamba vifungo viwili vya nyama na nini, lakini Wamasai wanakula paja zima kila siku, lakini hawapati colorectal cancer. Maybe wanazo, lakini hawatusikii, lakini we need data as well. So whatever we are doing, let's do surveillance so that we can also our own patterns here, because there's a lot of genetic variation and morphism that is coming, and we are seeing a lot of Western diseases coming to ours. With, in fact, even we are not even sharing the same lifestyle as they are doing. So I think surveillance and increasing screening programs, as we rightly put it, will also give us a picture of colorectal carcinoma pattern in our region. Thank you. That's a general comment.
Thank you very much, Dr. Ragasha, for those highlights. I really appreciate it. And now, Professor Mwakigonja, I can see your hand. Please, we are sorry to have to come here. We still have about 15 minutes remaining, so we have some time.
Good morning, ladies and gentlemen, and thank you very much, presenters, for a very interesting presentation, as well as contributors. I have interest in a few things. One of the things which has
caught my attention is the fact that this is more prevalent, said to me, in dark-skinned people. Now, we know that dark-skinned people are not only Africans. We have dark-skinned Asians, like the picture showed us. We have dark-skinned Aborigines in Australia, Australasia, the Maoris and other people. And then when it comes to the colon, you have got melanosis coli as well. So what is it about? Are there genes that which are associated with dark skin? Because now it's not about being African; it's about having dark skin. Are there genes which increase the risk to colorectal cancer, which are associated with dark skin? And if we are able to detect these, maybe we can do, because nowadays you have prophylactic genetic vaccines, but you can also have therapeutic genetic vaccines. So we can probably introduce an intervention, and maybe studies like gene microarrays or genome-wide association studies and other things can help us to actually pinpoint what is the thing about being dark-skinned. And is there any association? You did not say whether melanosis coli increases the risk. And is melanosis coli also more prevalent in dark-skinned people as well? That is one thing which caught my attention. And then the fact that colorectal cancer is being seen in younger people. When I was a fourth-year medical student, I saw very terminal colorectal cancer in a 15-year-old boy with a frozen abdomen, carcinomatosis peritonei, and the only thing which was done was palliative colostomy. And then we left everything in situ. I remember I was in Professor Mbembati's unit by that time. Now, that tells us that it is the modifiable risk factors which come into play if the age is changing, because age itself is not modifiable. But if we are seeing this in younger people, then maybe it is modifiable factors, which means lifestyle. If you talk of obesity, you talk of diet, you talk of smoking, you talk of alcohol, you talk of red meat, then these are all things which are associated with habits. And I'm surprised that you don't come out very strongly in your recommendations in behavior change. I always talk about MUHAS. MUHAS has got 2 degrees which are related to behavior change. We've got a master's in behavior change, and we've got a master's in behavior change communication at MUHAS. That means behavior change is a big issue. That's why we thought we needed 2 degrees just to address the issue. So maybe we need to even interact with the people teaching this degree. How can we do behavior change so that we can prevent, even before we need colonoscopy and other things, people change behavior and reduce the risk, at least the modifiable factors. Probably we cannot do much about the non-modifiable, then colonoscopy will come into play. Anyway, I will reserve other comments we can discuss in the sidelines. Thank you very much.
Dr. Omar, I think you're ready. After Dr. Hudson will be next. So you can unmute.
Good morning, everyone. Thank you for the invitation, for extending this invitation. I think it's a long overdue topic, if you ask me. I worked at Ocean Road from 2010 up to 2016 before I moved to Aga Khan. So I think during my experience at Ocean Road, we started seeing this coming in, colorectal cancer coming up. And probably Professor Faria might be right. our ability to diagnose probably was increasing, because back in the days, even endoscopy services were not really available. Were only available at Muhimbili. And I remember during my training, it was only Professor Aziz who was doing endoscopy. So probably our ability definitely has increased. But I also concur with Ria in the sense data is only the only thing that will tell us. I also have the same feeling that we are seeing younger population compared to the elderly populations if you compare with the Western data. But we have a data, a cancer registry at Aga Khan there. Going through that registry for the last 5 years, my hypothesis was nullified in the sense that, yes, we have seen these numbers or spikes of young presentation, but if you take overall that number, it gets diluted with the elder population. So probably because as doctors, we sympathize when we find young patients. I remember treating the youngest I treated is a 12-year-old girl. So probably we sympathize. And of course, when it comes less than 40 years, they usually face an aggressive disease compared with the ones that we see at elderly. So to me, my humble request is to do what other Western countries have done. We need to have cancer networks. We need to collaborate. Using Aga Khan data alone is very minimal data. Using Ocean Road data alone is also very minimal. But if we work as a consortium, we work as a network, we get Bugando data, Benjamin Mkapa data, KSMC data, Ocean Road, Muhimbili, Aga Khan, and other private facilities that treat cancer. I believe having those data can really help to inform the policymakers. Because what I see is other cancers are given more priority by policymakers because probably a high-profile person have been affected by that disease. Prostate cancer was given a big hype, and we were even pushed to start population-based screening, while we know evidence does not support that, because just a high-profile politician suffered prostate cancer. So I think it's high time for us. We use data, and we as scientists should be the one who stimulates the health policy of the country. We should be the one informing the policymakers, not the other way around, that we get directives from the policymaker. Second, I think I also wanted to talk on genetic profiling. I saw that was one of the recommendations. Very, very important. Our sister institution in Nairobi got a grant for testing KRAS G12 mutation, G12C mutation. So there's a substitution of guanine to cytosine. So when this mutation happens, or if you have this mutation, you are definitely going to have a cancer in your lifetime, definitely. And in the US, they have drugs now which are active, targeted this TKI. So it's a TKI inhibitor to prevent cancer. And if you get it, if for colorectal, it becomes very aggressive. But it's for literally, you can get any cancer. So when they got these funds from this company, they wanted to implement in Nairobi, while screening all our cancers in Kenya, did not have this mutation. Did not have this mutation. So definitely means in our population, there's something else that is driving these cancers. So for us, we need to have now our own data. We need to have our own genetic profiling of our tumors to understand what is the mutation that is driving these cancers in our population. So and the only way, again, we need to have networks. We cannot only use Muhimbili data. We need to, because these patients are so many. So for us, we need to have data of all of them. And then lastly, I'm also worried that as we are stimulating screening, and I think this is what what politicians always are afraid of, is we will create a demand, right? Once we raise awareness and we promote, we're going to create a demand. People are going to be demanding now, and we know the gold standard is doing a colonoscopy. Are we able to provide the colonoscopy towers in every of our regions? Because the minimum probably should be every regional hospital should have this, right? That should be the minimum, right? Are we going to be able to do that? And then treatment. Once you diagnose them, are we able? Can our health system absorb these patients and treat them? I think these are pertinent issues, which I think while we are discussing this, should go hand in hand with policymakers as they are budgeting to make sure that the infrastructure, the healthcare system is ready to absorb this number of patients that are going to be picked. Thank you.
Is the data. We need to have our own data. I think we began, even Kitua presented our local data, but certainly we need to have across the country data that will inform us what are the gaps and what are the things that we need to do. Interesting to see the mutation on TKI, which whenever you have it, then certainly you have cancer. But in Kenya, none of the patients had this mutation. Maybe we are completely different population from Western world. That's interesting to know. Yeah. Yes.
Just because of my environment, we know that viruses drive a lot of cancer. Is there any interest actually to make sure, just to rule out? Because we talk of cancer, there's non-communicable diseases, but quite a number of cancers are communicable. Some of them are caused by viruses, bacteria, fungi, and the parasites. And so maybe we need also to look at any local, especially in a continent like Africa, are there yet undetected viruses which may be driving this?
Thank you, Prof. I think these are the research question, and good enough we have many residents here who are on due for their proposal development. These are the research questions. Of course, we only have human papilloma virus for low down tumor, but colorectal cancer yet to be studied in that aspect. Allow me to read just a few questions here before we turn to wind up our presentation. Number one, which was asked by, I think this is Professor Omar Mies. What has caused a decrease in colorectal cancer in the developed world? And is there a relationship with inflammatory bowel disease such as Crohn's disease? I think, yes, in developed world, what have largely reduced the colorectal cancer, we said, is screening, population-based screening. Certainly it is expensive, Dr. Tua highlighted. It's very expensive to have such undertaking, and you should have capacity to attend those whom you detect. So it is a very infrastructure versus the expense. Should it be cost effective? But certainly in the developed world, it's because of the screening program in place, people are screening. I think in Germany, Dr. Rogasha might tell you, in Germany, I think you'll be called like a week before. We are reminding you next week you are supposed to go to your doctor for colonoscopy and the other screening program in Germany, I think, and many other Scandinavian countries.
Professor Menzi, you can interrupt. You can interrupt, Professor Menzi.
Yes, in etiology, inflammatory bowel disease is highly implicated in colorectal cancer. It's good that we don't have much of inflammatory bowel disease in this part of the world, but we see them now increasing. Ulcerative colitis is noted more in colorectal cancer than Crohn's, but nevertheless, both have got risk towards colorectal cancer. Another question that is asked, any findings about geographical problems, patterns of those diagnosed with the colorectal cancer? We were trying to go through the map, the world. It seems like the disease is widely distributed. In Africa, we have paucity of data. Looking at the map, it might mean that in Africa we don't have much of colorectal cancer, but one reason is because we are lacking data. Again, Professor Mlini's again, what do you see at MNH, the difference in terms of prevalence of the disease between female and males? From our data that we just presented here, we did not find any difference in sex between male and female, but certainly this is just a small data. We need to have more data to be able to answer this correctly, maybe countrywide data to be able to answer this correctly. Thank you. And the question to presenter, what is the result turnaround time of diagnosis at Mwanga? Maybe Dr. Rajash and Dr. Machigonja will answer this, especially for biopsy. Turnaround time for, yeah. No, it is up. Yeah, that one. So diagnostic way, colonoscopy biopsy results, CT colonography, radiological reports, fecal occult blood test. Thank you. So maybe Professor Machigonja, if you have biopsy today submitted to pathology from colonoscopy, what is the time when the results should be available? For CT colonography, then it should be between 1 to 2 days. You perform it today, tomorrow you'll have your reports available. I know we have Dr. Angela, radiologist, will tell us how long does it take. The one who is standing back. Okay, Professor Machigonja, biopsy.
Yeah, turnaround time for histopathology is between 7 and 14 days. So 7 will be the minimum and 14 days will be the maximum for these tissues which are not bone. Okay, bone will take longer because of a process we call decalcification. Now that does not mean you cannot get results before 7 days, but we talk of 7 working days to 14 days. But many times you can get results before that, but that gives us, breathing space because we receive specimens from all over the country.
Thank you. Anything from imaging? We have radiologists. Dr. Angela, can you tell us if you perform virtual colonoscopy today, when should we have the results in hand? Thank you. Advera.
So, experience that we get from the Department of Radiology, there's
Mari. Okay. Kwa hiyo tunafanya
which is 24 hours.
24 hours. Thank you. Yes, Professor Omar Mizi, I know you are online. You want to contribute something? You are welcome. Can you hear? Professor Omar Mizi. Okay, Dr. Advera. Okay, Dr. Advera, I think you wanted to contribute something. Okay, the last point before we wind up is the insurance. When I wanted to say maybe the PFA is here. Can we institutionalize this? MNH and the MUHAS staff to receive this color at the institutional level. Only yesterday I found out that we know all of us are insured, but I think screening is not part of insurance. Maybe this one will be left to the big bosses here if they have anything to contribute. Otherwise, colleagues, thank you very much. Okay, Dr. Jan Ragasha.
Okay.
Okay.
Whereby all other methodologies have not been able to detect. Otherwise, once it is discovered, you will have to put somebody for biopsy.
Okay.
So let's really reinforce our capacity and make utility of the conventional colonoscopy measures.
Okay.
Yes.
Thank you, Dr. John. CT colonoscopy should not replace colonoscopy, because if you perform CT colonography, then eventually you'll have to go again to perform colonoscopy for biopsy, unless there is a strict indication. At this point, may I invite the Dean School of Clinical Medicine to say a word, and maybe to invite the other university administrators for a word. Thank you.
Thank you very much, Dr. Mwanga. And I'd like to take this opportunity to congratulate the Department of Surgery for preparing this pertinent symposium. So congratulations, guys. Please give them a round of applause. It's clearly shown that since colorectal cancer is an NCD, and there's clearly a connection with other medical conditions or lifestyle. So I think it's high time now we follow the recommendation that we are given. And maybe Professor Furia will agree with me that most of our parents like to see their children a bit overweight. Okay, so they eat a lot of processed food, high fat diet. And maybe you are seeing these cancers early because the children have been primed, yeah, since when they're young to eat this type of food. So maybe it is high time now to change that. So without much further ado, may I welcome acting of BBC BFA for the final word. Thank you very much.
Thank you, Dr. Fra, for giving me this opportunity. As joining other people who attended this meeting, I would like to congratulate the Department of Surgery for their presentation to make us aware of what is happening in our bodies. But to join others as well, especially thinking I'm coming from the finance and planning, one of the common issue in our society is to screen for something which is not feeling it. And as we have seen, this condition is not painful at the early stages, so you cannot think about it. So I'm happy that you are among your plans to go to the community and educate them, and maybe you will adopt the mode by Professor Furia of saving money by taking that literal things. But really, we need a community awareness. I had some few issues from the first presenter, Dr. Kitua. When you said clinical presentation, you mentioned of features of metastasis. Maybe we have to define it clearly. What will you see clinically, the features of metastasis? But also, for us basic scientists, we are fond of knowing the mechanisms. So despite mentioning of the inflammatory bowel disease, maybe we would like to have the mechanisms that the inflammatory bowel disease can lead to colonic cancer. But in alcohol, we have to be a bit sensitive here because the government gets taxes from alcohol, and also people use alcohol as a source of entertainment. So when we go to the community, we have to be clear to differentiate us. When I say us, I mean you. To differentiate us and others who are also preaching about alcohol, so that the message is clearly understood by the community, and also they adhere to what you advise them. After saying these words, I'm happy that the turnout today is very high. I have been attending some of the presentations here, but people are very few. Maybe the point was of interest, but apart from getting the message from this presentation, the attending most of the presentations here leads for people to understand what is happening in other areas, but what the others are doing and what can be adjusted or can be improved so that all we are in the same bucket. After that, I wish you all the best.
Thank you. Thank you very much, Professor Mbugi, for your remarks. I think when the senior most person has said, then I don't need to say more. Thank you very much, and thank you for attending. It is time already. I think we meet in the near future. Asanteni sana.